I'm a breast cancer survivor. Oh my God, this is the first time I say it.
Good afternoon. We are gathered here today to continue our series on the care of the patient with HER2 positive breast cancer, specifically relating to new advances that suggest that there is significant value to the use of preoperative or neoadjuvant chemotherapy in the care of these patients. Unfortunately, that also means that there has to be significant improvement in communications between the patient and the physician, as the patient may not, in fact, present to undergo surgery for many months after they have started their treatment. And during that time, they have to be supported to understand that the use of chemotherapy in this setting is actually not only beneficial, but will actually be a very good measure of their long-term outlook. And for that reason, we need to then involve the patient in the decision to proceed with such an approach. And this so-called shared decision-making is part of our discussion today. In our panel, we have a number of colleagues, both patients and administrators who work here in the hospital, and I'll have each of them introduce themselves. I am Rivaldo Silva. I am a surgical oncologist. I have been doing surgical oncology since 1985, and I now work at the Fred and Pamela Buffett Cancer Center, which is part of the Nebraska Medical Center. Without any further ado, I'll have my colleagues introduce each other.
Hi, I'm Diana Keene, and I am a patient navigator.
My name's Laura Campbell, and I'm the program coordinator for the Navigator program here at the Fred and Pamela Buffett Cancer Center.
My name is Meg Ursick. I'm a nurse case manager with the medical oncology department here at Nebraska Medicine.
I'm Denise Bridigan. I'm a nationally certified health education specialist and an assistant professor here in the College of Public Health.
As we have indicated in our introduction, they undergo surgery, and that is our biggest challenge. We have to be able to convince patients that the delay in surgery will not affect their long-term outcome, and in particular, the response to chemotherapy is so favorable that their patients and our ability to explain why this is important may allow them to ultimately show that the neoadjuvant chemotherapy causes a complete resolution of their tumor, what we refer to as a pathologic complete response. And this particular feature, a pathologic complete response, has been associated with a remarkable improvement in disease-free survival at 5 years. Therefore, patients who are patient enough and who understand that this is a long-term plan will realize at the end of the day that this choice will lead them to a situation where their long-term survival may be markedly improved. However, this patient, keep in mind, will have the cancer in situ. The cancer will remain in their breast for several months, and there are few people who cannot worry that doing this may lead to a continued spread of the cancer, and this is where we have to then become quite involved in assuring them that this will not happen the minute they start their treatment with neoadjuvant chemotherapy for their tumor.
I was concerned about having the chemo first because you always hear people have the surgery first and then they have the chemo. But what made me think it was a good choice was what Dr. Silva said.
Some of our patients have had cancer in the past, or I should say some of our navigators are not only navigators, but are also patient cancer survivors. And among them is one of my colleagues in our Navigator program who can then tell us how best to prepare a patient for that long delay between the time they start their chemotherapy to the time they ultimately undergo curative surgery. Dan?
I think what is most important is to be able to explain to the patient, the patient has all that fear. They've been told they have cancer. They're scared, and rightfully so, because they automatically think they have that death sentence facing them. But what is most important is that if it's explained to them in really simple terms for them to understand, they can understand that it's beneficial to them to have that chemotherapy beforehand, and that the cancer, as long as they're receiving that chemotherapy, it is killing those cancer cells.
So it's quite often the case that patients need some kind of measurable assurance that the decision they have made is correct. And we always impress upon them that if they do embark on this particular approach, the HER2 positive breast cancer is bound to have a measurable improvement in their tumor within 2 treatment cycles. And this can be as little as 6 weeks. So we ask them to indulge with us and be a little patient, and you'll find out that many patients, after they start therapy, will realize that they may actually experience a 50% decrease in the size of the tumor after only 2 treatment cycles. That's 6 weeks. Not a very long time to ask them to just go along with us. You will find markedly that within 1 or 2 cycles, the shrinkage of the tumor makes the patient committed to completing the chemotherapy, and they will do so far more than if they had undergone surgery and never had any idea that the chemotherapy was working in their own particular situation. Our navigators are led by our coordinator, who often gets calls from patients who are concerned that maybe the tumor is not shrinking fast enough, and we need to basically assure them that they just have to be a little patient, that in nearly every case, in almost 80% of the patients, there will be a 50% reduction in the size of the tumor in less than 2 or 3 cycles. If we see that, as Laura can attest, you can encourage the patients to stay on the treatment to its completion, which may still be several months thereafter. Laura?
Definitely encouraging the patient to stay with it. If they can actually feel that the tumor is shrinking, it's really reassuring, and it makes it a lot easier when they're experiencing a lot of the side effects like nausea and hair loss, things like that that can really impact their daily life. So yeah, getting that, in that halfway point when they're in the thick of experiencing those side effects, it's really important. Our navigators are really great about, like, I experienced this myself, or even if they didn't experience it, they can really reach out to the other navigators and say, hey, I have this patient who's experiencing this, what can I tell them that can reassure them and have them continue treatment?
Unfortunately, many surgeons who see patients like this may miss that opportunity and may take the patient to surgery before the patient, for example, has been tested for a potential BRCA mutation, which is not unlikely present in young individuals with HER2 positive breast cancer. However, we aim in all these cases to have the patients visit with the medical oncologist and our colleagues in medical oncology before any decision is made regarding surgery. The reason for that is that our colleagues in medical oncology can then review the plan and, in essence, revisit that plan with the patient before any consideration is given to surgery, and perhaps assure them once again that the approach of neoadjuvant therapy in the HER2 setting is the best approach. One of our nurses in medical oncology, unfortunately, is tasked often in trying to convince patients not to jump at surgery, but to consider this option, which we all know is in fact the best option.
Right, and I think the important thing is that we have a united front, and I think it's helpful to kind of work interdisciplines, because they've probably built a trust with the surgeon, and now you're asking them to leave and come and meet a new doctor and a new set of caregivers, and so rebuilding that trust, or being able to reiterate what they've already heard, almost when people get a second opinion, they just want to hear the same information more than once, and that helps to assure them that, okay, this is the right thing. And so I think just having this interdisciplinary consistency, and if they're hearing it from you, they're hearing it from me, and that we collaborate probably helps to build trust as we work with them through the system.
Listening to that, I feel like I was very lucky, very, very lucky. I was taking care of a team, and the doctors talk to each other. That's very important, the communication between one doctor and the other. And I was offered the options. I don't know, I was very, very lucky. Very lucky. And just so they know that we trust them. And if they prepare themselves for this trust that we give them, that's so important. We really trust them with our lives.
And I think it's important to realize that many of these patients who ultimately make this decision should know that the most recent approaches with combination chemotherapy in the HER2 patient have shown a nearly 70% complete pathologic response. That means 70% of the patients who complete this treatment and then go on to surgery are found to have no evidence of residual tumor in the breast. And remarkably, this response is independent of the size of the tumor. A 5 centimeter tumor will respond just as well as a 2 centimeter tumor. So the odds of that complete pathologic response are not relegated only to those with a small tumor, but are also seen in patients with what we consider locally advanced breast cancers that may ultimately result in the avoidance of a mastectomy. And those patients can then go on to have breast conserving surgery. Now, unfortunately, many patients are still under the presumption, or assumption, I should say, that somehow breast conservation may be less of an option or less of a medically acceptable option than mastectomy. The public perception still, in many cases, is that mastectomy is a more aggressive treatment, which in fact we now know is not true. Dr. Britigan, in terms of patient information or patient health literacy, this is a big problem, that the public impression is that somehow mastectomy is better when we as physicians know that it is not necessarily so.
You're right. Unfortunately, unless there are campaigns to dispel and share the correct information to the public in very understandable terms, then that misperception of the idea will continue. And so that communication between the patient and the provider is very important. And one way of approaching that is to ask what's their understanding at the beginning of the conversation, and then start from there, just so that the provider has a clear understanding of what they're up against as far as what needs to be corrected.
Now, we have also noted that there are some misconceptions in the community, and when we started our Common Navigator program here, we realized that they varied among individuals of different cultural groups.
And in one of the calls, a cousin of mine said, that's because you live in the U.S. and that lifestyle you guys live there gives you cancer. Had you stayed here, that wouldn't have happened.
There is clearly a public perception that a double mastectomy is the only treatment for breast cancer nowadays, and there has been a great debate in the medical literature over the years trying to see how shared decision-making can actually reverse that trend. The same way, there are many who still believe that, as we said earlier, a single mastectomy may be better than breast-conserving surgery. And these are all unfortunate hindrances to this approach. After all, we are trying to delay a surgical treatment and overcome all of these anxieties and misconceptions. What do you think?
Well, I think a lot, women who are diagnosed with breast cancer and they decide to go down the mastectomy route, I think there's a lot of outside factors. A day doesn't go by where you don't see some famous actress, a news person or something, being diagnosed with breast cancer, and they immediately do the mastectomy, and because they think their whole theory is, if I do the mastectomy, the cancer's gone, I'm done. And I think that's a big misconception that people have, and that's, needs to be explained to them. And then, of course, people, they ask their friends, they ask their neighbors about what they did. And so I think that's, factors in there also. Because if they see somebody who had a mastectomy and they're fine 10 years down the road, well, then that's the route I'm going to take because it worked for them. But what they don't understand is because what works for one person doesn't necessarily work for everybody, because there are so many different factors that go into breast cancer.
I know that I've seen that with patients who especially have like a family member who has gone through any sort of, if it's that my sister died, so I need to take this more aggressively, even if there's been genetic testing. It just changes their whole mindset. Or well, the chemo is what killed them. I hear that a lot at different health fairs and everything. So then they're less, they're more hesitant to participate in the chemo or preoperative chemo. They just want to get it off and done with. And so I think that has a huge influence on their availability to have the preoperative chemo.
And I think just the new treatments too, exactly like you said, if people say, well, my grandmother 20 years ago or 30 years ago, had chemotherapy and it was terrible. And I think just you had kind of touched about understanding where they're coming from. If they're hearing from their church pastor or for someone in their community, that is really strong to them, and they'll carry that advice probably more so than they will from their surgeon or their medical oncologist. But helping them to understand, what advances have been made and advances not only in the treatment but in the supportive treatment and the anti-nausea treatment and all of those things that are drastically different than treatment they've maybe witnessed a family member go through 10, 15, 20 years ago. It's really, things have really changed.
Well, I think that's a very important point, because the new approaches to the management of the HER2 positive patient have relied heavily on two drugs specifically that are not what we would normally call chemotherapy. These are antibodies, and their side effect profile is remarkably tolerable. It's only the combination of these two drugs with chemotherapy that does introduce some of the problems that we share with patients who are undergoing standard chemotherapy, but our medical oncologists can often tie them through that initial several month period during which they are receiving the standard chemotherapy, often in combination with the new agents. But soon thereafter, when that cycle of the standard chemotherapy is done, the remainder of the chemotherapy treatment is based on these new agents, which are remarkably easy to tolerate. I'm sure you have seen that, right?
Yes. Yeah. Right. Sometimes they're surprised and sometimes they'll say, "Are you sure you gave me the right medicine? I feel fine." So, but actually, that education ahead of time also, in that it is okay to feel okay. That you don't have to feel miserable, and sometimes it is because of the supportive treatment we have, or that anti-nausea medicines and those kind of things, and just that everybody might experience this differently, and that it's okay. And I think having someone to call, a navigator or a case manager, especially up front, that care coordination, you give them so much intense care up front until they feel comfortable and start to build that trust and okay, I got this now, I know what to expect, and they become their own best managers. This is what I did, and then on the third day I know to do this, and but that's really scary to not know what to expect. And so being really available whenever they need you to be up front, I think helps kind of alleviate some of that as you go.
And we actually addressed that early on. Among the things that we like to see, Dr. Pritigan, is that the patients not be alone. And to that extent, I always have them come back with another family member or someone else, purposely, because although I will leave with them a fairly numerous sheet of papers that includes a timetable, and the timetable that we draw starts on the day of their visit and is concluded on the day they finish all of their treatment, at which time we always say they can go out and celebrate. And so when you do see someone who shows up to clinic, even more so, unfortunately, among the culturally underserved community, we really have to have someone else come back with them. Otherwise, they really do get lost in the shuffle. And that's where, in the absence of such a person, we have our navigator program, but it is immensely helpful to have a relative to come along with them. Dr. Pritigan, what do you think?
I agree with you very much. So if a navigator isn't available to them, at least having someone be their coach throughout the process. And it's not too unlike with a birthing coach. It's a 9-month process and happy endings hopefully at the end. But with the helping someone else through a process that's long-term like this is important. The other point that you mentioned is that you provide materials to individual tailored to the patient, and that's so important and so appreciated that you do that, that you take the time to draw pictures and to walk them through not only the timeline and what it's going to take, but the fact that you address the information at the level of understanding that's required for that patient, and that you check for that understanding along the way is also important. And the fact that another person present and listening to that, to watch for facial cues and body language that lets them know maybe that family member or friend isn't quite getting it, and just feeling in a safe way to encourage them to ask questions when they don't understand something is very helpful.
It's so important to have someone with you. You don't absorb, but maybe 20% if that. So I always had someone go with me, and then I would ask a question at home, and my husband would be like, well, yeah, they said this. Don't you remember? And I was like, I have no knowledge of that. I don't remember any of that.
I think that's truly the case. I just saw a patient whose brother came to accompany her, and he was taking furious notes of what I was about to undergo. And then, of course, when I handed him my sheets with the timetable and everything, he said, well, maybe I should have just listened instead of writing notes. In a way, this approach is ideal for such patients, for example, the gene carrier, because it does allow for several months during which the patient can undergo counseling, genetic testing, meet with the plastic surgeons, learn about nipple skin sparing mastectomies, which we perform at our facility, and all of those things can be done in a relatively modest pace. There is no hurry, because while they're undergoing those discussions, they are already embarked on their treatment. So there has been no delay to the beginning of their systemic therapy, which also adds to the advantage of this approach. We have all the time in the world to get plastic surgical consultation, genetic counseling, and genetic testing. As Dr. Brittigan pointed out, the patient literacy becomes an issue. However, the good thing about this is you still have weeks during which you can visit. The oncologist, the medical oncologist will visit and encourage the patient about how well they're doing. And I think the patient doesn't have to make that abrupt decision. You know, unfortunately, the days of when a woman went to sleep, not knowing if she will wake up with the breast or not, are not yet behind us. And we have all seen women who went to sleep with a lump in the breast, not knowing if they would wake up with or without a breast. And so this is the other end of the spectrum. This is a situation where a woman has all of the time necessary to be able to make an informed decision in a matter of months. And during that time, she's not going to be losing any ground as far as her care. Dr. Brittigan, what do you think?
I think it's important to, as you say, make sure that they understand that that's not time lost and that they're not behind, but that they are in a process leading to an eventual good outcome, and that the information that's being shared is being shared in a way that's very understandable. So if the language, although the names of the therapies could be confusing, or of course you're writing them down for them, but that process and stepwise treatment for the timeline that you're following, if every step of the way that plain language could be used, very simple terms, everyday approach, that's very important, because it may sound like that's a very conservative way of approaching something, but sometimes that's the better way. I know just in my own life, I've had a knee injury that the orthopedic surgeon decided to treat conservatively with a cast for 8 weeks. And that was good for me with physical therapy afterwards, but the piece that they forgot to tell me was, of course, atrophy and the muscle reduction. When the cast came off, I was shocked because one leg was half the size of the other, and so I burst into tears. I always think back on that in my own life and think, what could I tell someone so that to better prepare them for what to expect? And so having that conversation over a period of time as to here's how you can speak with this specialist and how you can speak with this specialist and what will you learn from each one. As long as it's kept very clear and using language that's understandable, then I think it adds to the patient's reassurance that they're making progress. It may not seem like it right away, as you say, hopefully in a cycle or two they're feeling a difference, but palpable difference, but at the same time, you want to make sure that they're on board with the fact that this is being very conservative, but we're making unseen advance.
I'd like to close with a statement for those of you who are, in fact, health care workers or physicians or surgeons. Among patients today, as we speak, who undergo breast-conserving surgery, the number of women who return to the OR for a second or third operation because they have margin-positive disease at the time of lumpectomy still runs between 40 to 50% throughout the country. 25% is a reasonable number in most hospitals. However, you know that if these individuals will have to undergo chemotherapy by virtue of the fact that they are HER2 positive, the use of preoperative chemotherapy has been shown to decrease margin-positive rates of lumpectomy by nearly 80%. Keep in mind that the person who has a breast-conserving procedure with a lumpectomy and returns to the hospital to learn that her margins are positive and thus she needs another operation will more often than not opt for a mastectomy as the next choice of surgery, and that would have been unnecessary had this option been considered beforehand. I'd like to thank the members of the panel for their comments today. Thank you.